Okay, in the interest of time, since we're a couple minutes in already, I'm going to go ahead and get started. As you can see, we're still working on sharing the screen and hoping our Zoom participants are able to hear us and see us. But good afternoon, everyone. It's my pleasure and privilege to serve as the CGNE administrator. My name's Janice Whitaker, and this program is being presented by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Ross and Carol Neese College of Nursing, in collaboration with the Office of Outreach and Professional Development, as well as the Center for Nursing Research and Age-Friendly Care, PA. Today's seminar, Infection Control Strategies in Long-Term Care, Lessons Learned from the COVID-19 Pandemic, will be presented by one of our CGNE's favorite collaborators, Dr. Nikki Osevala, who will be introduced in a moment. But before we begin the presentation, we do have some disclosures and announcements. The Pennsylvania State University campuses are located on the original homelands of Erie, Haudenosaunee, Lenape, Shawnee, Susquehannock, and Wazizi nations. As a land-grant institution, we acknowledge and honor the traditional caretakers of these lands and strive to understand and model their responsible stewardship. We also acknowledge the long history of these lands and our place in that history. I'd also like to read the PSNA disclosure piece. Penn State Ross and Carol College of Nursing is approved with distinction as a provider of nursing continual professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and Accreditation. Participants with a valid RN license who attend the entire nursing continual professional development program can earn 1 contact hour. Partial contact hours are not awarded. This topic of education is non-clinical, and therefore we did not identify, mitigate, or disclose relevant financial relationships. In order to earn contact hours, Zoom in and out time will be recorded, and the post-event evaluation survey must be completed. This seminar is being recorded. If you have any questions, of course, if you're in person, you can raise your hand and ask them aloud. If you are joining us via Zoom, Jenny will be monitoring the chat feature. You can also raise your hand and Jenny will unmute you. We will be doing a post-event evaluation at the end of the session today. We'll save 5 minutes at the end to do that. That link will be put in the chat, and for those of you that are here in person, Jenny has a QR code. She's on it that she'll be sharing with you. And then certificates will be mailed to RNs that meet all the requirements within a month after the session. And if you have any questions at all, you can reach out to cgne@psu.edu. Next, I'd like to introduce Nahida Akhtar, one of our CGNE PhD student affiliates. Nahida is very actively engaged with our center, and we wish to congratulate her on her abstract, Person-Centered Care Influences Resident Satisfaction in Long-Term Care, that has just been accepted for poster presentation at ENRS. So thank you, Nahida, for introducing our speaker today.
So thank you, everyone. Dr. Nicole Osevala is an internal and geriatric medicine physician at Penn State Health Milton S. Hershey Medical Center, where she is the interim chief of geriatric medicine and medical director for the Penn State Health Post-Acute Care Service. Dr. Osevala cares for older adults in a local nursing home, as well as provides geriatric medicine consultation for geriatric trauma patients at Hershey Medical Center. Administratively, Dr. Osevala has championed the creation of a post-acute care network for Penn State Health patients with the goal to improve care transitions, quality of care in nursing homes, and ultimately improve outcomes for this vulnerable population. In the hospital, Dr. Osevala launched the inpatient geriatric consult service in 2020. and has convened stakeholders in March 2021 to embark upon the goal of becoming an ACE-friendly health system at the Milton S. Hershey Medical Center. Dr. Osevala has led the South Central's Regional Response Health Collaborative Program, the Regional Congregate Care Assistance Team, and currently leads the Resiliency Infrastructures, Supports, and Empowerment Program, which supports 90 nursing homes and 150 personal care homes across 13 counties in South Central PA in COVID-19 outbreak response, staff education, emergency management preparation, and community building to create a sustainable response to crisis in long-term care. So let's welcome Dr. Osevala.
Thank you.
So this will be a little weird till I figure out advancing screen and looking at my screen. So we'll see her on the Zoom.
Yes.
Okay, thank you for that welcome. I will start by saying that infection control 3 years ago would not have been the topic I chose to speak about. It wasn't an area where I had much focus at all clinically. And really through the grant work that began in July of 2020, things changed dramatically. I've spent the past 2.5 years going out to nursing homes and personal care homes, experiencing COVID outbreaks with a fabulous team. But I've had the chance to really kind of look under the hood as to what's going on, both from a day-to-day resident care perspective, but also infection control. So a lot of what I'll talk about today is a reflection of what I saw, because I know there are some big thinkers in the room and on the line. And hopefully some of what I share in what we've observed will give us ideas about how we can better support our nursing homes and personal care homes as it relates to infection control moving into the future. And so if you would advance your slide. So during the talk today, I'll identify 5 contributing factors to suboptimal infection control in long-term care communities. I'll take some time to discuss some of the complexities that we encountered with CDC and CMS guidance implementation, particularly as it relates to viral transmission in long-term care. And then I'll offer some practical strategies. These are not going to be anything that are earth-shattering. What I'm hoping for is it sparks some ideas of how you might be able to help us approach transmission of respiratory viruses, but infection control in general moving forward. So when I began thinking about actually what topic I would share today, really in the back of my mind was this thought of reflection of what we've been through. It's been so busy managing COVID outbreaks and then trying to find our new normal that I don't know if everyone has really had a chance to kind of step back and think about what we went through, particularly in that first year of the pandemic, before we had vaccines, before we had therapeutics. And so I'm gonna start by talking about that before we move into some of the observations and future directions. So some of you may recognize the name of this center. This is the Kirkland Life Care Center. This was the first nursing home in the United States that experienced a COVID outbreak. This was in mid-February of 2020. By the end of their outbreak, they had 80 residents who had passed away from COVID-19 out of about 130 people. So it swept through that community. They couldn't even test at that time. If you remember, there was no testing, even had to go to a state bureau of labs. You can advance the next view. Yeah. So this is again, them just taking a resident out. Next slide. So it wasn't long before communities in our area started to experience outbreaks as well. So Spring Creek Nursing Home, that is a nursing home that used to be a county home. It's 400 beds, 8 units. They have a respiratory area, they have a behavioral unit there. And when we got the call in March that we had an outbreak and my providers work in this building, we were terrified. The first patient that they identified had actually been sent out to the hospital very ill. And essentially in the first round of that outbreak, there were 222 cases out of 340 residents who lived there and almost 80 deaths. They suffered a second surge in the fall with 180 cases and about 75 deaths. If you think about that, 25% of the residents there died from COVID-19 before the end of 2020, essentially. Next slide. Now, I will say Spring Creek is a 2-star nursing home. Okay, so I think early on we thought, well, you know, the people that struggle to perform day to day, they're the ones that are going to really be impacted. You know, the higher performers, you know, hopefully they'll be able to maintain infection control and perform better. That didn't turn out to be the case at all. In fact, every nursing home has had an outbreak. Messiah Lifeways, I point out, they're a 5-star nursing home just down the road from Spring Creek. They had actually more deaths than Spring Creek, an equal amount of transmission. Both nursing homes, both my 2-star and 5-star, needed National Guard support because so many staff were out sick. So it was, you know, devastation, like utter devastation. And so thinking about how we move forward is, you know, where I want to go. I'm going to just share some stats for you because I actually was a little stunned when I saw this. So primarily the total nursing home COVID deaths. This slide I actually created in March of 2021 for my geriatric rounds for the Department of Medicine. And when I went back in to look at the total deaths in nursing homes as of yesterday, they're about 163,000. So if you think about the volume of death that occurred, it was within that first year of the pandemic. Again, when we didn't have the necessary tools, not only from vaccine and treatments, but also PPE supply and testing capabilities. And so, you know, it's just another way to highlight how bad it was when all of this began. Next slide. So what is happening what was happening that causes nursing homes to really struggle with infection control? Well, I've heard one doctor make an analogy that it's like a nursing home is like a cruise boat, right? You're in tight quarters, people are in shared rooms, often there are shared bathrooms. In general, there are congregate activities, and it turns out during COVID, it didn't matter that all the residents were confined in their room. There was still tremendous transmission. Our patients have a very high nurse to nurse or nurse aide ratio. So, you know, one staff person taking care of a large number of people. In many instances, the infection preventionist is also the ADN or the wound nurse. They often have multiple roles. And then there were basic infection control challenges, like many of our sites didn't have mask fit testing. So those N95s have to be fit tested to make sure they actually protect you. Most of our sites had no mechanism whatsoever to do fit testing, even if they could get access to N95s. PPE training and monitoring, environmental health staff and space and adequate hand hygiene stations. And in reality, the resources weren't limitless, I'm sorry. They don't have the types of resources that big health systems and hospitals have, where they can buy $5 million worth of protective equipment and store it in warehouses. And so they really struggled with the lack of resources. Next slide. So I think it's important to point out that we had problems before the pandemic. So it wasn't just we had this highly contagious, deadly virus that, you know, came to the United States and we somehow, even though we're perfect in infection control, it still ravaged our nursing homes. It turns out we weren't doing so well in the nursing home space pre-pandemic. So 82% of CMS certified nursing homes had at least one infection-related deficiency between 2013 and 2017, and about 50% had infection-related deficiencies for multiple years. And so now I'm going to kind of talk about more specifics around the contributory factors. This article is actually fantastic. It did an environmental scan essentially throughout the pandemic to identify the areas that were most vulnerable. So I'm going to go into each of these in detail. Next slide. So in terms of staffing, we found that there was a direct relationship between adequate nurse staffing and infection transmission. This isn't just the fact that there might be one staff person to 20 residents. And so if one staff person has COVID and doesn't have a mask fit tested N95 that they're going to infect 20 people, but also the staff moved from different facilities. So many of our nurses would work in 2 or 3 different facilities, or they might be agency staff that were moving around. And they found up to 50% of the cases linked back to staff were related to agency staff that had moved between buildings, which was kind of shocking to hear, but yet made a lot of sense based on what we had seen. There was ongoing chronic staffing shortages, high staff turnover, staff, as I mentioned, working multiple facilities. And on this side, I think this is where we felt it the most, because we would, when they had a staffing crisis, for example, we'd say, well, can't you hire more agency staff? They simply were priced out of the market in some cases to even have staff to come in. They also reported excessive paperwork. There were actually 3 different reporting systems that our nursing homes in Pennsylvania had to report into every day throughout the pandemic to report all of their not only positive but negative cases, because they wanted to see the volume of testing relative to the positive cases, along with a federal reporting system. So think about that when you have an outbreak and people are dying and you don't have enough staff, and the data is important, but the reporting requirements were substantial. Next slide. From a resource perspective, the non-compliance with PPE, there is a mixture of lack of knowledge, along with perhaps not believing in the need for PPE, I'll put it that way. But also just challenges with maintaining infection control because of the supply issues. When you walk into most healthcare facilities, there are alcohol-based hand sanitizer dispensers all along the walls. In the hospital, it's like outside every patient room. Some of our nursing homes had none, not one, or they might be tucked away in an area. And so when you have staff that already may be having compliance issues and they have 20 patients to take care of, but they have to walk all the way down the hall to sanitize their hands, do you think they're going to sanitize their hands, or are they going to move on to the next room? Really basic things. Limited availability of private rooms. So we have nursing homes that still have quad rooms, so 4 people to a room. You can imagine when one resident gets COVID, so do the rest of the roommates. And it makes it really hard to move people around when you have a lot of room sharing going on. And so the sparsity of private rooms was a real issue. And then we also found infrastructure-wise issues with air handling. The way that air handling systems are set up in nursing homes, depending on how old the building is, vary widely. And there were concerns at times that it was the air handling that was contributing to transmission, because there was air being shared across rooms where there may have been COVID cases and non-COVID cases. Next slide. So just wanted to share some pictures throughout this presentation of what we saw and what we were looking for when we went into COVID outbreaks. So we really focused on break rooms because there was a lot of transmission among staff. And what we found was the staff were compliant on the unit, but then they go into their break room and the mask would come off, they'd be sitting close to one another, they wouldn't wash their hands. And so we would often go in and kind of scope out their break rooms to see, do they have space to store their PPE? Do they have hand sanitizer, et cetera? Next slide. We even went looking around where they kept the ice to see, do they have gloves there? Because if you're going to dig in and scoop out a cup of ice for the residents, do you have gloves? Is there hand sanitizer? These things seem so minor, but when you, especially early on, when every single case led to the possibility of the resident passing away, it became really important to look under around every corner. Next slide. And then these are some pictures of what it looked like in our nursing home. So if you've done any clinical rotations, usually you doff in the room. So you don in the hall, which is your clean space. You go into the room with all your PPE on, and then before you come out, you're supposed to take your gown and gloves off, wash your hands, and leave. Well, these are hallways, and this was because they couldn't find enough garbage cans to put in the resident rooms to be able to doff in the room. So we would coach them on doffing in the room and then carefully taking it, putting it right into the trash can, and then sanitizing. But these are things that I don't know that a lot of people saw, and you would think, well, why can't they just go buy 100 garbage cans? Well, at the height of the pandemic, you couldn't find them. Even the storage bins to keep the PPE clean so it didn't get contaminated in the hallways. So again, just a little bit of what it looked like in these spaces early on in the pandemic. Next slide. So moving on to the third contributing factor, it was around the infection control education. I will tell you, even when COVID began, they lined all the providers up at Hershey Medical Center. We went into the sim lab and showed people that we knew how to don and doff our PPE and it was just show them and go. But our nursing homes didn't have that. And so if they didn't have staff that were trained in that, and again, we have the benefit of having lots of infection preventionists, the staff may not know how to properly don and doff their PPE. There were other challenges as well: language, culture, different terminology for different things, and the leadership really being overextended so that they couldn't audit to make sure there was compliance or give feedback to their staff. Next slide. And then on the implementation side, I will say from an infection control perspective, there were some things that in theory should have been in place that would have better prepared our nursing homes, like in 2016, CMS required antibiotic stewardship programs and required an infection preventionist. So again, really trying to get the nursing homes to like beef up their infection control knowledge base and resources. But in practice, there are just a lot of problems. They don't have an infectious disease doctor to call when they have a question. If they have to do a swab or a test, it has to be sent off site. You can't get results instantaneously. And I shared the challenges around sharing roles between a DON or ADON and infection preventionist. But it really came down to a lack of resources being able to maintain solid implementation. Next slide. Now, on the bright side, in this study, they did find some bright spots in terms of organizational culture that really can help nursing homes perform better. And a lot of it, though, hinges on all of those contributing factors I've just been talking about, having adequate staff and resources, having shared accountability, a just culture, high-level administration, endorsement of infection control habits. But when they do perform in this kind of organizational culture type of way, they have improved outcomes, there's less burnout, there's improved job satisfaction. And so we really need to kind of get away from like all the things that were bad and weren't in place during the pandemic and kind of move towards what do we need to do better when we have the next global pandemic with a highly infectious and deadly virus. Next slide. So I'm going to kind of move on and just also now give you a little flavor for what they were experiencing from a regulatory perspective. So I will tell you, in my role, I was responsible for also digesting all of this information, and I went back and counted about 40 health alert network memos basically that were issued. They usually flow down from recommendations that come out of CDC. CMS will sometimes endorse them at the same time or wait, but then they come through the Pennsylvania Department of Health. And if you think of 40 updates to guidance, that's a lot of material to take in. These aren't one-pagers. Sometimes they're like 15 or 20 pages with all sorts of intricacies to how they want you to operate. Next slide. And so when you think of all the dizzying changes to guidance, I thought it was interesting, and I may have missed things on the pre-COVID side because I'm not a nursing home infection preventionist. But in my provider brain, I was like, okay, before COVID, we screened for TB. We had our precautions for patients that came in with known infections like C. diff or an MRSA infection, for example. And we might, on a weird year, have a flu outbreak. Okay, that was like the extent of infection control in nursing homes pre-COVID. I'm not going to go through this lengthy list in the interest of time, but you can see it's huge. And it's not just a long list, but the things within that. So testing 400 staff twice a week, testing 300 residents twice a week, reporting all of those tests into a computer system, managing your PPE supply, making sure your staff know how to don and doff. I mean, the amount of infection control requirements that flowed from this pandemic relative to what nursing homes knew was like drinking through a fire hose. You know, really hard to manage. Next slide. So I'm going to go through just a couple of areas of the changing guidance, just out of interest to folks in the group to understand where our facility, our nursing home communities really spend their time. Next slide. And so on that first green square, you saw this concept of crisis contingency and conventional use of PPE. Okay, in the beginning, we were in crisis mode. Okay, people walked around with the same gown on all day. That's not good infection control. In and out of rooms, to your nurse's station, not good. We also had to conserve PPE. So when I would go into nursing homes, the first thing I would look for was to see how they were storing their N95s, because they were issued 3 and then they were supposed to rotate them, and they could wear them up to 5 times and then they would throw them away. So we would go in and look to see if they were following that advice, how they were tracking it, and if they were actually, you know, after 5 wears, discarding the N95. The next slide. This is inside, or it's just beyond a, you can see the double doors there, a COVID unit. And you can see all of the equipment kind of lined up on the outside of the door. But again, in normal times, you should not be seeing people walking around with gowns on and all of this PPE. Even in the hospitals and our COVID units, we would just don our N95 and our gowns, go in, see the patient, and then doff, come out, and then put our surgical mask back on. But in these nursing homes, if you have an outbreak, you wear an N95 all day, because they can't close doors, because the residents need the nurses to be able to see the residents. And so everything was contaminated, basically, because we didn't know what space was clean and what space wasn't. Next slide. There were also things like temporary barriers to create COVID units. So these were zip walls erected by facilities to try to keep the COVID space, you know, separate from the non-COVID space. This was actually allowed until just this summer. These are fire and safety hazards, apparently, but there was a waiver, and so they were allowed to use them. And so even as recently as last week, we're working with places that didn't realize that this isn't allowed anymore and have been using them to create some COVID units in their buildings. Next slide. And just another example, sometimes they got clever and tried to just create like ante-rooms if they had like single patient cases as opposed to entire units. Next slide. And just one more. Okay. A lot of pictures. The other thing we had to do was cohort. So we had a green, yellow, red zone concept. Okay. So imagine trying to move 20 or 30 residents to different rooms so that your COVID patients were separate from your non-COVID patients. So for quite some time, I would say about a year and a half, we had zones. If you were unexposed, you were in the green zone. If you were exposed, you were in the yellow zone. And if you had COVID, you were in the red zone. As a staff person, having to move not only the resident, but their belongings, and then sanitize rooms so you can move people around. Again, along with all that other stuff I listed they have to do to manage an outbreak, you can start to get a feeling of how intense this was for staff. And it's kind of amazing that many of them are still here after seeing everything that they've gone through. Next slide. Oh, you can advance. So, you know, just some things that we saw that contributed to the transmission early on were staff crossing zones. It was simple things like they would pull their med cart from a non-COVID space to a COVID space and then back out. And we're like, now you just drug that into your COVID unit and it really needs to stay back there. Having dedicated equipment for that space, having low PPD. So nursing homes, from a regulatory perspective, they're supposed to have a PPD of 2.7, and that's basically a ratio of how many staff you have relative to the residents in the building. We found that a lot of our nursing homes needed at least a 3.2 level to maintain. And I can tell you most of them, even when they didn't have an outbreak, were lucky to be at 2.7. And if staff were out with an outbreak, they were in the low 2s. And that was when we were allowed to call the National Guard to come in and help support them, because we knew there was no way they could survive and take care of the residents properly without that support. We noticed a lot of breakdown of IP practices in break rooms, which is why we were scouting them out quite often. not storing their PPE correctly, trouble with cohorting. So imagine if your mom was in a room with someone who tested positive for COVID, but they said, well, we can't move mom until tomorrow. You know, imagine this before vaccines and treatment, where you're like, oh my gosh, like get my mom out of that room. So challenges like that contributed to transmission. Having trouble keeping up with the guidance. And then I will tell you that dementia units were our biggest struggle. Those residents like to move, they don't wear masks, they like to touch everything, they like to be close to one another, and that is not a good combination when you have a highly transmissible deadly virus on the unit. And so there was a lot of transmission on dementia units. And we tried to do creative things like if there were fire doors that could be closed on a unit, just to reduce the wandering, to try to strategically place chairs further apart. So if they sat down to watch a movie together, at least they were spaced. But the dementia units posed a particularly great challenge for us. Next slide. So amidst all of this, where can we focus? You know, where can we spend our time thinking about how to improve infection control, not only now, because to be honest, when we have COVID outbreaks now, it's a rarity that someone dies, but there's still a lot of transmission. We can have 30 or 40 cases in some of our buildings because they've resumed group activities, you know, lots of visitors, all great stuff for the residents. So I don't want to, you know, by any means suggest that that shouldn't be happening, but there's still a lot of COVID in our nursing homes. So what can we do to help reduce the spread? So I think, and I'm a mom, so I think to myself, what are the things I can control? Because there are things in life that are just outside of your control, and you just gotta like throw your hands up and go, I'm not gonna be able to do anything about this. So environmental controls are an area we can focus on. High quality infection control training for the staff with audits. Preserving space so that as you plan renovations, you can start creating more private rooms. And this sounds crazy, but just where you place your hand sanitizer and your PPE, because as silly as that sounds, I've seen it a million times. If an aide has to walk halfway down the hall to retrieve the PPE she needs, she's going into the room because she's busy and she's got 5 other people to get to. So how can we make it so that it is super easy for them to do what we're teaching them to do? Next slide. So from an environmental control perspective, and oddly enough, early on in the pandemic, I worked with some of the engineers up here to look at air handling in some of our older buildings and nursing homes. But it's also just coaching on opening, if you're going to have a large gathering, opening windows and doors if the weather will allow, increasing ventilation in the room when you're having gatherings, rather than having 4 or 5 people at a table, having fewer people at a table so they can still interact. But if one of them happens to be sick, instead of 5 people, it's maybe 2 other people that get sick. Using all the space you have. A lot of times these, you know, the dining rooms are all kind of closed in, but you can really use your space to spread things out. Doing a better job disinfecting high touch spaces. And the residents that can, asking them to mask, because that's another thing that just was not happening by virtue of the residents not being able to wear them properly or not tolerate them, was that it was very rare to have our residents properly wearing masks, even at the height of the pandemic. They tried, but it was really hard in translation. The high quality staff training and audits. So this is something that I hope in future years we'll be able to really ingrain, is that on orientation and multiple times a year, there is this rehearsal of how to properly don and doff. I can't tell you how many times someone has, you know, they take off their gown, they've just been in a room with COVID, they take off their gown and gloves, they sanitize their hands, and then they take their face shield off, and then they touch their mask, and then they start touching themselves. And I'm like, because, you know, in theory, the mask is contaminated too. So, you know, it's those basic reminders, like actually everything on you that was this way facing the patient is contaminated, and you have to handle it like it is. The use of training like the blow germ gel with the UV light. I don't know if you guys have ever had that exercise. It's pretty cool. I think it's like, it's scary to see the germs that are left, but it can teach them like really how long it takes if you're going to use soap and water to really clean your hands well. Having secret shoppers every shift, someone else to do the audits for the leadership to assess compliance, but a non-punitive approach. These people have been through a lot. We're lucky they still come to work and do what they do. I think there are ways to encourage all of these infection control measures that don't require punishment. Next slide. And then again, really basic things. Every time I go to an outbreak site and they still don't have hand sanitizers mounted, I'm like, you need one like every 2 doors. They have a hard time even getting them every door, but at least get some along the walls in the hallways. Make sure that they have a reliable supply of PPE. Make sure if they have a COVID person that the PPE is right against where they're going to enter the room. You'd be surprised how many places I go where they're still walking, to an area where all of the PPE is to retrieve their supplies, and then waste bins inside the room. I told you this wasn't going to be anything earth shattering. And then use of space. So actually the CMS just last year issued guidance and they're doing away with quad rooms, which I think is long overdue. So as rooms are being renovated, they need to move away from the quad rooms to doubles. But also we really try to coach our nursing homes on keeping a bed or 2 open for if they have a case so that they can properly cohort. And then using the entirety of space when there are gatherings. Next slide. So this is my last slide and really is more of what I think about in the mess of all of what our long-term care communities went through over the past few years. And that is that, infection control is one area, but it's a lot bigger than infection control. It has to do with the organizational culture. It has to do with what the standards we hold our long-term care workforce to. There are certain standards when you work in a hospital. There are certain standards in other clinical settings. I will say, working in all different settings, the bar is set low for them. I think they can do a lot better, but when you're around people that set the bar low and don't really encourage you to move above the bar, you kind of settle for mediocrity or lax, not only lax infection control, but lax patient care. And that's not what we want for any of our older adults. So the National Academy of Science, Engineering, and Medicine issued a report in the spring. It's lengthy. I think it's like 500 pages, and then there's appendices after that. But they have 7 overarching areas where they want us to be thinking about in terms of how we transform our nursing homes moving forward. I do think that what happened in the nursing homes during the pandemic has gotten the attention at the federal level to a point where we understand we can't continue to operate like we have and expect things to get better. So the name of the report is called the National Imperative to Improve Nursing Home Quality, Honoring Our Commitment to Residents, Families, and Staff. And I love that title. And really it is a playbook for what those of us who live and work in the space of nursing homes can think about and how we can advance the care of the residents, the quality of care that's delivered, but also other domains that are really going to have to be reformed if we hope to see a transformation in the long-term care space.
All right, well, thank you so much for an amazing presentation. That's certainly made everything feel very real. And I think many of us remember a lot of what you spoke about, but you certainly added another layer of detail with your experience, your background and experience. So thank you. We can certainly take questions either from the room here or via Zoom. Is there one via Zoom? Let's start with Zoom then.
There is. Sister Agnes asked, was the educational preparation or standards for long-term care rethought from the COVID-19 experience?
I will say that is actually being rethought. In fact, we were talking about that earlier today when I met with some of the faculty here. Right now, and I've learned a lot about the underbelly of the nursing homes, the competencies that are required and the amount of training, and more importantly, the quality of training is not standardized. It is not examined closely. And I think this is an area coming sharply into focus for CMS in particular. And while I don't think that there has been dramatic change, I think this is a space where it is ripe for significant change in how we educate this workforce. Not only those in training to become nurses or aides, but what we do once they're hired and how we maintain those high standards of care. Thank you.
I was gonna ask along those same lines. So for the next pandemic that comes, like what would be that one thing that you would implement from all of the stuff that you have learned? If you had to pick one thing and then why?
And the staff went along with it?
Anything.
Yes, your magic wand.
You know, honestly, and I'm gonna knock on wood, I've not had COVID despite having taken care of and been in some raging COVID outbreaks. The PPE use, if you know how to handle yourself, PPE, donning, doffing, hand hygiene, you're aware of, you know, what is around you, what you've touched, you will be fine. And there were severe challenges, and I alluded to this earlier. We would have staff go and take care of a COVID patient, come out of the room with the same gown on, and then go right up to their med cart, leaning on it. Okay, now I'm gonna go pass meds to the next person. And then when they were done, they'd go sit down at the desk at the nurse's station with their contaminated gown on, because their perception was it's protecting them, but they didn't understand it was contaminated. So there was like that basic just misunderstanding of what the PPE was there to do. It's the same thing with like touching everything. It's like, stop touching everything. Every time you touch, you wash your hands. You know, your hands probably should be raw by the end of a shift. You know, if you're washing them often enough, especially, you know, in the earlier days of the pandemic. So that would be, I think, the PPE piece would be the area I'd focus on.
Donna?
Well, it's just a follow-up from that comment, because I was thinking in my head, being ICU nurses, that's such a shift of thinking, because their thinking is this is everyone's home and we don't do that in a home. Whereas in a hospital, I think we're more used to doing that. But anyway, I think your presentation was amazing, having like watched our local nursing home that also lost, you know, close to 80 older adults. So thank you for bringing in the human piece and your insider, and then the little like practical understanding what they're going through. I have a really practical question, and also a comment is, when you talked about culture, is I think the other thing the NASM report brings out that's relevant to everybody on Zoom and at this table is the need, and this is where our center comes in, of course, is the need for more geriatric and medical and nursing leadership in nursing homes. And so, for instance, a lot of people that are leading this aren't well trained in geriatrics. So, you know, thank goodness that they had your leadership. So, you know, I guess I'm saying that so that everyone around the table thinks about going in and being a leader in that setting, because I think that's one of the big focus of the Teaching Nursing Home Project and the NASM report. The other one is ageism. So you showed that slide, 163,000 people, but guess who got PPE first? Nursing homes got it last, because we're this like hidden group of like, you know, there are actually headlines that said, it's okay, it's only old people dying, you know, so anyway, fabulous presentation. Practical question was, when you gave that slide about staffing levels associated, and you said, who was the author of that paper? Sort of your.
It's in my references.
Okay, so
Yeah,
we'll
the last
get-
slide is references. I'll share it with
So
you.
we'll get that, because
Yeah.
I think, I remember reading that paper, but I couldn't remember and my eyes couldn't see it. But
Yeah, I don't think I threw it up on the slide, but I have a nice little long list of references on the last slide. I'll share it.
Yeah, thanks. So
Yeah.
anyway, amazing presentation.
Thank you.
Any other questions or comments, feedback? Liza?
Of course, I love your presentation. Great job. Mine's, again, a bit of a practical question as well, as we're sort of thinking about the pandemic being over and going into endemics, and taking into account that the culture, right, of nursing homes is that it is their home. And so I wonder if you've seen any changes, one from the provider perspective in terms of how they're more consistently or inconsistently using PPE on a regular basis. For example, I was in a home this past week. And they still have all their setups, right, for visitors when they come in, and they're still separating their residents. So there's still a lot of inconsistency, and I'm just wondering if you're seeing the same thing. That's sort of one part of the question. The second part is, do you see the leadership in that particular home? It's like, well, we hear, like we had 40 sort of memos on what we should be doing to protect residents, but there's never a memo that says you can stop doing these things.
Right.
So how do you foresee nursing homes being able to? move
Yeah, so
forward?
right now, the CDC guidance is still in counties that are in high transmission from a healthcare transmission level, so not the community levels, which have been low, thank God. That means hospital capacities are holding. But almost every county, except for 2 in the area I cover, have been in high since almost May. So the CDC guidance is surgical masks and eye protection if you are in a healthcare setting in a county in high transmission. Now, once we move into substantial, moderate and low, God willing, in the next month or so, then it becomes optional for staff to wear surgical masks and eye protection in patient care areas. They've already relaxed what you can do in the non-patient care area, so you can choose to not wear a mask in, like, administrative offices, even in the kitchen, et cetera, but they're supposed to be wearing masks when they're doing direct patient care. From a when will we have normalcy again, and I've gotten this question many times, I don't think we're gonna have what was normal before the pandemic ever. I think we're gonna have our new normal. But it's gonna be a non-panicked, we know what we're doing response when we have a COVID case. I think the vaccines were nothing short of a miracle in saving lives early on, and then the monoclonal antibody therapy. And as long as we continue to have vaccines and therapeutics, as it relates to COVID, we should never see, the degree of what we had to do happen again. But I think from lessons learned, we're going to have to think long and hard about what we would manage differently if we were put in the same circumstance again.
Sharif, I think I saw your hand.
Yeah, yes, thank you for the brilliant presentation. Actually, one part of my question has already been answered. So, but the second aspect, you identify the chronic shortages as one of the contributing factor. And when you have made mention of the what next, what we should focus, do you think staffing issue can also be a contributing factor to the infection control? Because at the end now, you identify a chronic shortage, especially during the pandemic. As situation change, if not, what are the practical issues on ground that can improve the staffing ratio in the long term?
Well, a lot of the current grant work I'm doing right now is related to how to address the staffing shortages, because the turnover in the nursing homes is a lot related to what chaos not only transpired then, but even now, because when you're short-staffed and you are running around all day long and you're still not feeling like you've met the needs of the people you're caring for, that's highly unsatisfying. Like, who wants to go to work and feel like at the end of the day, they worked really hard and they still feel like they did a crappy job because they simply could not get to everything that needed to be done. So I think we put the staff in untenable positions that why would they want to stay? So, the path out of that is we need to make nursing homes an awesome place to work, that's rewarding, challenging, that there are career ladders, that you can see a future for yourself being there, because they're great places for a sense of community. And some organizations do it really well, and they have staff that work there for 20+ years. But that's not the majority of them. So it's kind of like we have to figure out what that secret sauce is. It's probably a combination of the leadership, the culture in the building, but also the resources that allow the staff to do what they're there to do and feel good at the end of the day, that they had the time they needed to do a good job taking care of their patients.
Do we have any Zoom questions, Jenny?
Yeah.
Okay.
Just to build off of that, what is the current political landscape in terms of making pay for nursing home staff equal to that of acute care facilities, right? Because currently they're paid a lot less. And then where are we, or have we made progress in getting rid of agency staffing, particularly for nursing homes, right, which
Agencies were like a blessing and a curse during the pandemic. We had contracts in my first grant, I had contracts with 3 nursing agencies because we needed to find nurses and they would come in from other states. From a policy perspective, I know at least for Medicaid, they have increased the payment slightly, and I believe from a regulatory perspective, they're planning on raising the minimum PPD, which ultimately should result in nurses not having 20 patients to take care of over the course of a shift, and reducing the ratio of nurse to patient, which hopefully will make that work environment better. But I don't think those 2 things alone are going to solve the issue, because even if you don't have as many patients and maybe you're getting paid a little bit more, if it's still not a pleasant place to work and you still don't feel like you have a career path to follow, and you don't feel that sense of community, when that higher paying job at the hospital or a desk job comes up, you're going to take it. So we really do have to figure out how to make nursing homes like the cool, fun place to work. And I mean, for those of us who love older adults, it's like, I wouldn't work anywhere else. We have to help other people see that and feel that way, if we want to get to a different place, because it's not always about the money. I mean, it's about the money, but it's not always about the money. So
I think, yeah. There, I wish we had more time for Q&A and discussion, but Donna, our fearless leader, Director Dr. Donna Fick, is going to do our closing remarks. And then just as a quick reminder, Jenny will put the link to the evaluation tool in the chat, and she'll share the QR code with those of us in the room. You can do it now. You can do it anytime within the next week, if you want to have those contact hours.
Yeah, so I want to again thank you, but I also want to say, like, everyone knows I can talk today, but also thank you and our college today, during the college, because I've really seen like our partnership elevate over the past years. And so we're appreciative of that. Some of you that may not know this, we have multiple projects that we're collaborating on, and that, Janice is on, and others. So I just really want to thank you for that, and say that I think the things that you brought to that are interdisciplinarity, so you have nurses, you have physicians working together, that, is really, really appreciated. I think evidence-based, we saw that in your talk today. And then I think joyfulness, that we share this passion for the care of older adults. And for all of you students out there, if you want to know what will sustain you, 40 years from now, I think that's what's it. So we have a little swag for you. And I'm thinking that Janice was reading your mind, or Jenny was reading your mind, because I'm pretty sure there's some hand sanitizer in here.
too much.
Always gotta get the PPE.
And make sure you also take out the envelope and the chocolate. And
Oh,
thank you again.
thank you for having me.